Hello everyone, Dr. Beena here. Today's topic is iron metabolism. See, iron is an important trace element essential to the life, and it is 75% of the iron is in blood, and the rest is seen in the liver, bone marrow, and the muscle, and it serves both as an electron acceptor and an electron donor. So iron is the most important trace element essential for the life, and 75% of iron is seen in the blood. It is seen in the hemoglobin, so it is majority is present in the blood, and the rest is seen in the liver, bone marrow, and the muscle. And the main function is it is serves as an electron donor and an acceptor. So, how much is the total iron content of the body? The total body iron content is 3 to 5 grams. So, altogether in the body there are 3 to 5 grams of iron. Heme is the predominant iron containing substance. Out of this, heme is the predominant iron containing substance. Now, we'll see how the iron is distributed in the body. It is distributed as three types: as heme proteins, that is heme containing proteins, and then as the non-heme iron containing proteins. It is not heme but iron is containing in that pigment, and there is iron requiring enzymes. That there are certain enzymes which requires iron for the action. So like that we can divide into three types. Heme proteins. See, what are the heme proteins? It is mainly hemoglobin. 60 to 70 percentage is hemoglobin, then myoglobin about 5 to 10 percentage. So these are the important heme protein, that is heme containing iron, and along with the protein it is present. Then non-heme iron containing pigments. They are not hemes but they are iron containing pigments. What are they? That can be either storage iron proteins and transport iron proteins. So storage iron proteins are ferritin, hemosiderin. So iron is stored in the form of ferritin or hemosiderin in the body, and they are the non-heme iron containing pigments. So ferritin and hemosiderin as the storage iron proteins. Then there are transport iron proteins when it is transported in the blood, that is transferrin. Transferrin is a transport iron protein, and it is usually seen 1 to 2 percentage. So roughly all these together forms the total iron content of the body. And third one is the iron requiring enzyme, that is only minimal amount. 1% of the total iron is in the form of some enzymes present along with the enzyme for various activities. Important ones are catalase, xanthine oxidase. There are so many enzymes which contains enzyme or requires iron for the enzyme activity, that is given in your book, you can refer. Now we'll pass on to the sources of iron. From where did you get the iron? That is, it may be either animal source or a vegetable source, or it may be from the body itself, that is endogenous source. So what are the animal source? Liver contains 5 milligram per 100 grams, and the meat contains 2 milligrams per 100 grams. So 100 grams of liver contains 5 milligram iron. Similarly, 100 grams of meat contains 2 milligrams of iron. Then milk is a poor source of iron. That is very important. So many people are thinking that milk is very good, but it is a complete food, but iron content is very poor. Then second source is the vegetable source. That is, leafy vegetables contains 20 milligram per 100 gram are the good source one, and the pulses contains 10 milligram per 100 grams, and cereals 5 milligram per 100 grams. Legumes, nuts, dates, etc. also contains 5 milligram per 100 grams, and the jaggery is a very good source of iron. So you can write jaggery as a very good source of iron, and you can also mention milk is a poor source of iron. Then endogenous, where will you get endogenous source of iron? That is by utilization of ferritin and the intestinal mucosal cells. So whatever iron which is not absorbed from the intestinal cells will be again utilized for the synthesis of various iron proteins or pigments. So that is the endogenous source. And also from the ferritin. Ferritin is the storage form of iron. So from this ferritin again we can use the iron for various purpose. So these are the important sources. So in the question, usually source of iron is an important part. Then recommended allowance, daily allowance is another part. So you have to study all the source, and it is very important. So in this picture you can see various sources and vegetarian and non-vegetarian source. Non-vegetarian meat, fish and egg. Vegetarian source lettuce, green leafy vegetables, etc. are there. Now what is the daily requirement of iron? RDA is very important for all minerals and vitamins. So here iron requirement, daily requirement is for adult it is between 15 to 20 milligrams per day, and children it is 20 to 30 milligrams per day, and for pregnancy it is more, that is 40 milligrams per day. Pregnancy, because the fetus has to grow inside the uterus, so it requires more, that is why 40 milligrams. Even the lactation period, when the baby is fed, that time also the lady requires more amount, about 40 or 50 milligrams per day. Now we'll pass on to the absorption of iron. How iron is absorbed from our body. That is, our absorption occurs in the body. Iron absorption is tightly regulated. It's a highly regulated process, and proximal part of the duodenum and the jejunum is the site of absorption. Proximal part of duodenum and the jejunum are the site of iron absorption. There are two major forms of dietary iron. If you are taking food, you will get two types of iron in the diet. What are they? That is heme iron, found primarily in red meats and is the most easily absorbable form. So heme iron is the one which is seen in the meat. So it is easily absorbable type of iron. Next is the other forms of iron which are bound to organic constituents of the food, sometimes to the proteins. So the other type of majority is seen in the organic forms bind to the various foodstuffs. So they are the other forms. And heme iron, which is obtained from the non-veg diet, that is in the meat, it is easily absorbable. Now, what are the factors increasing the absorption? Factors affecting the iron absorption. That is, when you have to write about the absorption, you have to mention what are the factors affecting, that is either increasing or decreasing the absorption. Iron is absorbed only in the ferrous form. Remember, it is only in the ferrous form, not in the ferric form. Sometimes along with the food, it may be in the ferric form, bound to the protein, and in the stomach HCl separates the proteins, and then ferric form will be there. That has to be reduced to ferrous, then only we can absorb the iron into the intestinal cells. Ferric ions are reduced with the help of gastric HCl, ascorbic acid, and sulfur containing amino acids. So these are the factors which increases the iron absorption by reducing the ferric ion to the ferrous ion. So only the ferrous form is absorbed. Remember, that is an important point. Ferrous form is only the absorbable form. So whenever you are taking food, it may be in the ferric form. It has to be reduced to ferrous by various factors like gastric HCl, then ascorbic acid. You might have studied, it is having a reducing property, so it reduces the ferric to the ferrous. Similarly, sulfur containing some amino acids also help in the reduction. Then there are other factors like gastroferrin hormone in the intestinal part, then small peptides and amino acids, alcohol and fructose. All these things will increase the iron absorption. Now we'll see what are the factors which decreases the absorption. Okay, so these are oxalate, phytates, tea or coffee, calcium, copper, zinc, lead, and phosphates, and the alkaline pH of the body. All these things will decrease the absorption. Oxalates are seen plenty in vegetables, and phytates are seen in cereals. So when if there is more vegetables, that is fiber containing things, then the content of oxalate will be more. Some, so that will affect the absorption. Similarly, phytates which is present in the cereals also decreases the absorption. And another thing is the calcium. Calcium always decrease the absorption. So if you are taking milk along with the iron tablet, the absorption of iron will be always decreased. Then copper also decreases the iron absorption, zinc also decreases, and the lead, phosphates, etc. Then another condition where the absorption is decreased is malabsorption syndrome like steatorrhea. There is a condition called steatorrhea where there is digestion is not occurring properly, fat digestion. So in that condition, there is decreased absorption of iron that usually seen malabsorption syndrome. Now we'll pass on to the various steps of iron absorption. The incoming iron, that is the iron which is taken through diet, is in the ferric state as we already mentioned, and it is reduced to ferrous by a ferrireductase enzyme which is spanning over the brush border cells of the intestinal cells, epithelial cells. So in the intestinal epithelial cells on the top there is brush border thing. There the ferrireductase enzyme will be span and kept. So these ferrireductase enzyme will reduce the ferric form to the ferrous. Then what happens after the reduction? Now it is ready for absorption, isn't it? Ferric is not absorbed, only ferrous. Now it is converted to ferrous form. Now there is a divalent metal ion transporter, that is DMT1, which is present in the surface. Yeah, interior, that is also present on the brush border surface, and then that will transfer the iron into the interior of the cell. So interior of the intestinal epithelial cells. So from the top, this divalent metal ion transporter allows the ferrous iron to enter into the cell. It is a protein transporter. So this divalent metal ion transporter is a protein transporter which spans over the membrane. That is usually seen spans over the epithelial upper part of the epithelial membrane. Understood that part? So through the divalent metal ion transporter, ferrous iron is entering into the cell. Now the ferrous ion absorbed into the mucosal cell is again getting oxidized to ferric. Peroxidase enzyme will be present in the cell that will oxidize the ferrous into ferric, and then this enzyme peroxidase will be present in the intestinal mucosal cell. Then what happens? The ferric then combines with apoferritin, a protein, to form the ferritin. So ferric iron plus apoferritin jointly forms the ferritin. What is ferritin? Ferritin is the storage form of iron. So in the intestinal epithelial cell, it is a temporary storage form of iron. When there is no enough iron, this ferritin will be released into the blood. Otherwise, it will be present in the cell as ferritin. So the fraction which is absorbed and retained is decided by the iron status. What is the meaning of that? Whatever fraction remaining in the ferritin in the cell occurs, that depends upon the iron status. If there is iron deficiency, the amount of ferritin will be less in the cell. because it will be mobilized to the tissues. If there is excess iron or enough iron in the blood, then the ferritin will not be released and ferritin will be less present in the cell enough. So the status of ferritin in the cell depends upon the iron status of the body. Understood that much? So whatever is present, first it is converted to ferritin. The ferritin is a temporary storage form that you have to remember. Whenever it is required, it will be taken out and transported through blood to reach the various places like bone marrow or the cells for the various activities. Okay. Now there is a transport protein called ferroportin. It is a transport protein. Now the iron is in the ferric form in the ferritin, right? So this ferric form of iron, when it is required in the blood, what happens? It is taken by the ferroportin, this transporter, into the basolateral surface of the epithelial cell. That is in the basal part of the cell, from the cell to the lower part of the cell. This ferroportin, a transport protein, is taken and it is released into the bloodstream. So the expression of ferroportin gene and the DMT, divalent metallion transporter, is down regulated by an epsidin, which is a polypeptide secreted by the liver. So how it is regulated, that is the absorption part is regulated by a theory called mucosal block theory, and how this theory works, that is what we are going to explain. The expression of, that is the synthesis of ferroportin and the DMT1 is downregulated, that is it is suppressed by epsidin. When epsidin, where is it synthesized? Epsidin is produced in the liver when there is enough iron in the body. So in the body, if there is enough iron, there is no requirement of further absorption, right? So in that condition, uh, liver secretes epsidin, a protein which will downregulate, that will inhibit the synthesis of ferroportin, which is the transporter form from the cell to the basal part, and the divalent metallion transporter, which is the protein which is spanning over the apical part for the absorption of ferrous iron into the cell. So both these are decreased when, if there is epsidin. So epsidin is produced when there is excess iron in the body. Now what happens if there is no iron in the body? The synthesis of hepcidin is not taking place. So there will be increased production of ferroportin and the DMT1. That is the regulation, the expression of the synthesis is increased. That is ferroportin and DMT1 numbers are increased. So more and more of iron is taken into the cell and it is released into the bloodstream for the various purpose. So that is the happening, that is the role of hepcidin. So that is a key regulatory part, that is hepcidin is the key regulatory part. Secretion of hepcidin occurs when there is iron stores adequate. In hypoxia, anemia, and hemorrhage, the synthesis of hepcidin is reduced and leads to increased synthesis of ferroportin. So, increased absorption of iron also occurs. So, when there is hypoxia, that is, oxygenation is less, when there is not enough iron. So, that condition is another condition is anemia, when there is no hemoglobin level is decreased again, and also when there is hemorrhage occurs, then also the level, iron level will be decreased. In all these conditions, hepcidin synthesis is reduced in the liver. If the hepcidin is less, then that lead to increased synthesis of ferroportin and DMT1, which will absorb more iron from the intestine due to this mucosal barrier. So this mucosal barrier is produced by the hepcidin, which is produced and which is acting on the ferroportin and the DMT1. So due to this mucosal barrier, only about 10% of the dietary iron is absorbed. So if you are taking 20 milligrams of iron, actually the required allowance, daily allowance is 20 to 30 or 10 to 20 milligram per day in an average adult. So if you are taking 20 milligram, only the 2 milligram will be absorbed. This is occurring by this mucosal block theory. Okay, understand that part. Whenever it is when the iron status is adequate, the epsidin is synthesized by the liver, that will reduce the expression of ferroportin and DMT1, so that no more iron can be absorbed. So if there is deficiency of iron, this epsidin is not synthesized, so there will more production of DMT1 and ferroportin, that will increase the uptake of iron into the cell. In anemia, iron is absorbed more. So that is, we have already explained. When there is anemia, the epsidin synthesis is not occurring, so the ferroportin and the DMT1 will be increased. That will absorb more iron, whatever iron is taken through our food. If iron is excess, absorption is reduced. So if there is enough iron in the body, the absorption will be decreased. If there is no iron in the body, absorption will be increased. That is the mucosal block theory. Ferroportin is an iron transporter protein, we have explained already, which carry iron across the mucosal wall. It occurs when there is free transferrin in the plasma. So what is transferrin? It is a transport protein of iron. In the blood, iron is transported in the form of transferrin. So this, whenever the level of free transferrin is uh, high, then the ferroportin is released from the mucosal wall. It occurs when there is free transferrin in the plasma. That is the duty of ferroportin, to transport the iron to the blood. So free transferrin means it doesn't contains iron atom. So that is apotransferrin. That is a protein. So if the level of the apotransferrin is more in the blood, that means it requires iron to carry to the various places. So in that condition, the ferroportin will production will be increased, and that will bind the ferric iron in the from the ferritin, and it will be taken to the bloodstream. Now, how the heme iron is absorbed? We have first told that there are two types of iron in the food, heme iron and non-heme iron. Heme iron is the one which is present in the meat, and it is easily absorbable. So how it is absorbed? It occurs separately. There is no mucosal block theory like thing for the regulation and all. It is directly absorbed into the cell. That is through a heme transporter. The separate transporter is available on the apical part, not the DMT1. So through that heme transporter, it is present. It is taken into the mucosal cell, that is inside the cell. This heme transporter is present on the mucosal surface. This absorption of this is impaired when there is calcium. So heme transporter absorption is impaired when there is calcium. That is why we already mentioned the factors decreasing iron absorption is one of the thing is the calcium. So in this picture, you can see the complete steps of iron absorption. This is the iron as red dots. This is the apical cell surface, and here there is apical transporter, that is DMT1, divalent metal ion transporter, through which the ferrous ion is entering. So first it may be ferric, and here there is ferrireductase enzyme spanning, that will reduces the ferric to ferrous. Now the ferrous ion is entering through the divalent metal ion transporter. Inside the cell, it is again oxidized by ferroxidase enzyme, and it is converted to ferric form ferric then forms the ferritin. So many atoms of ferric form join together to form the ferritin, which is the temporary storage form. Okay, now within the cell, storage form ferritin is seen, and if there is free transferrin, that is, this is the free transferrin which is seen here. That is this one transferrin without any this transferrin which is having iron is this one, but those don't have iron is this one. So when there is free transferrin here, it requires iron to transport. So this time here it is ferroportin. Ferroportin is present on the basal surface. What is the role of ferroportin? It will transport iron, ferric iron from this to the basolateral surface, and it is now in the ferrous state, and it is taken and it is going to the transferrin and forms the transferrin, apotransferrin to form the transferrin. In iron, homeostasis is maintained by regulation at the level of absorption. That is very important point. Usually regulation occurs at the level of metabolism or at the level of excretion, but iron homeostasis, the level of iron in the blood is maintained by the at the level of absorption, that is by mucosal block theory. So it is not by the excretion, and no other nutrient is regulated in this manner. So remember, only iron homeostasis is maintained at the level of uh, absorption. So there is iron is not excreted as such in the urine. Now, regulation of iron, various methods. One we have discussed is the mucosal regulation, mucosal block regulation. Second one is the stores regulation, and third is the erythropoietic regulation, and fourth is ferritin transfer in receptors. Out of which major important is the mucosal block theory. When iron stores in the body is depleted, absorption is enhanced or increased. That is the theory. When adequate quantity of iron is stored, absorption is decreased. So that is the one. When there is no enough iron, more is absorbed. When there is excess iron, absorption is decreased. This is referred to as the mucosal block theory. When the iron is in excess, the receptors, that is for the transferrin receptors are not produced. Enough iron is there, there is transferrin receptors are not produced, and that is the basis for the mucosal block. Now, stores regulation means as the body iron stores fall, the mucosa is signaled to increase the absorption. So, what is in what form the iron is stored? It is in the ferritin hemosiderin form. So, if the stores form is falling, then the mucosa can absorb more of iron. Another method is regulation is erythropoietic regulation. In response to anemia, erythroid cells will signal to mucosa to increase the iron absorption. So in the erythroid cell, there is an erythropoietin hormone secreted when there is anemia that will signals the increased absorption of the iron, so that more of erythrocytes can be synthesized and more heme can be produced. Okay, so that is usually occurs in the bone marrow, and that is usually in response to anemia. If there is anemia, body requires more of erythrocyte formation. For that, iron is required. That is by increasing the absorption. So again, there is a picture where you can see the various steps of iron metabolism. That is here. This is the um, mucosal cell, and then food is there, iron is there in the this thing red dot, and ferric form it is present. It is reduced by the ferri reductase to ferrous, then it is entering the divalent metal ion transporter. Divalent iron plus an hydrogen atom together is transported into the cell, where it is reaching in the ferrous form, then it is converted to ferric and then stored as the ferritin. This is the temporary storage form. Now, when free transferrin is present without any iron molecule, or this ferroportin which is present in the basal surface will transport the iron which is present as the ferrous into the bloodstream, and in the bloodstream what happens is it is again getting oxidized. Ferrous is getting oxidized to ferric by ferroxidase, that is by the ceruloplasmin. Ceruloplasmin is a copper containing protein which is present in the plasma, which has got a ferroxidase activity. So in the plasma there is a copper containing protein called ceruloplasmin which has got ferroxidase activity. What is the meaning of ferroxidase? It will oxidize the ferrous form to ferric. So when this is converted to ferric form, it will combine with the epotransferrin to form the transferrin. So this transferrin is formed, which is the transferrin is the transport form of iron. Remember, ferritin is the storage form of iron and the transferrin is the transport form of iron. So two molecules of iron atoms are attached to the apoferritin to form the ferritin. Not the ferritin, it is the transferrin. Now in the blood, iron is transported in the transferrin form. It is easy to remember. Transfer means transferrin. Transport form means transferrin. The storage form is the ferritin. Okay, ferritin is seen here, and this is the transport form transferrin. Then it is taken to the various cell for various function, and it is there are receptors, transferrin receptors on the cell surface. This blue one is the receptor, and onto this receptor, this transferrin is taken. Transferrin is taken, and it is whole thing is internalized. Whole thing is internalized, and finally the receptors comes out of the on the surface, and then the iron in the ferric form is again getting inside the cell. Either it will be stored as ferritin or as the ferric form, and it is utilized for various activity, either to form heme containing proteins or for the synthesis of hemoglobin or any other purpose it is used. Okay, so this is the place where the iron is utilized. This is the place where iron is absorbed. It is in the mucosal cell, and it is transported as transferrin and reaches the cell. Transport of iron is in the plasma. First, iron is liberated from the ferritin of the mucosal cell, enters the plasma in the ferrous state. That I already explained. It is first in the ferrous state, then it is getting uh, oxidized by the ceruloplasmin, a plasma protein having peroxidase activity. There is one more protein called peroxidase 2 in the plasma, which can also help in conversion of ferrous to ferric. So after releasing from the mucosal membrane, it is in the ferrous form. It has to be oxidized to ferric, then only it can combine with epotransferrin to form the transferrin, which is the transport form. So ferric iron binds with the specific iron binding protein transferrin or siderophilin. Transferrin has got another name. Old name was the siderophilin. So ferric iron alone can combine with epotransferrin to form the transferrin. So what is transferrin actually? It is a major glycoprotein beta 1 globulin synthesized in the liver, found in the blood, and it is an acute negative phase protein that you need not study. Anyways, remember that it is a plasma protein present synthesized by the liver, and it is a negative phase protein, and it is beta 1 globulin in the plasma. Carries iron away from the liver and the intestine to the various tissues. So its duty is to transfer iron from the liver and intestine to various tissues. Free iron form from is iron-free form of the protein is called the epotransferrin. Okay, then epotransferrin combines with ferric iron to form the transferrin. So that is how the transferrin is formed. So whenever there is free apotransferrin in the blood, what this ferritin will releases iron, and the ferroportin will take it up to the basal membrane, and in the blood ferroplasmin will oxidize the ferric iron to ferrous iron, ferrous iron to ferric iron, and the ferric iron combines with the apotransferrin to form the transferrin. So one molecule of transferrin carries two ferric ions. So to form one transferrin molecule, it requires two ferric ions. Then there are transferrin receptors present on most of the cells I have seen, and the iron transferrin complex is taken by the receptor mechanism that also I have shown in that diagram. It binds two molecules of transferrin, and the whole iron transferrin receptor molecule is internalized, or together it is taken into the cell, and iron taken and the receptors are then externalized. After taking the iron into the cell, the receptor again go to the upper part of the membrane to take another molecule. Now what is the storage form? That is ferritin, that is formed in the liver, bone marrow, spleen and the intestinal mucosa. Usually seen in the intestinal mucosa, it has a temporary storage form, and it is, if there is more iron, it will be stored in the liver, bone marrow and spleen. Apoferritin got 24 subunits with 3000 to 4000 iron atom per molecule of ferritin. So large quantity of iron is stored in the ferritin molecule, and the level of ferritin is an index of the total body iron stores. If you measure the ferritin, you can get an idea of the total iron stores, how many irons are present, how many iron content is present in the body. So normal level is 300 to 400 nanogram per deciliter, and ferritin content is increased in hemochromatosis, that is iron toxicity, and it is decreased in iron deficiency anemia. So when there is increased high increased level of ferritin, that is giving a clue that is having hemochromatosis. Hemochromatosis is a condition where the iron toxicity occurs, excess iron is present. Iron deficiency anemia, there is decreased level of ferritin. Another form of storage of iron is the hemosiderin. It's again a storage protein, iron storage protein, and derived from ferritin. So it is a partially denatured ferritin, complex aggregate of partially denatured. When the ferritin is partially denatured, it forms the hemosiderin, and when there is iron overload, hemosiderin pigments will be deposited in the tissues. Usually seen in iron overload, it accumulates in the body, that is usually seen in the spleen, liver, when the supply of iron is excess when the body demands. So it is usually seen in the spleen and liver when the supply of iron is in excess of body demands. ബോഡിക്ക് ആവശ്യമുള്ളതിൽ കൂടുതൽ വന്നു കഴിഞ്ഞാൽ ഇറ്റ് ഈസ് സപ്ലൈങ് ഇൻ ദ it is present as the hemosiderin in the liver. Now the excretion. Very little of iron is excreted. That I already explained. There is no excretion of iron. The level of the iron is maintained by iron level in the, or iron homeostasis is maintained at the level of absorption, not at the level of excretion. So very little iron is excreted, almost nil. In the urine it is almost nil, but some quantity is excreted through feces, that is unabsorbed part in the desquamated epithelial cells of the intestine. There, we have already explained that ferritin is stored in the intestine. If there is no requirement of iron, what happens is when the intestinal mucosal cells are desquamated, along with that some amount of ferritin also will be excreted through feces. That is the one way by which it is excreted. The regulation of homeostasis is done at the level of absorption. We have already studied. Almost no iron is excreted through urine. Feces contains unabsorbed iron and the iron trapped within the intestinal cell. That is what I explained now. Whatever iron is there in the mucosal cell, which is not needed for the body, when the desquamation of the cell occurs, when the cells are destroyed, wear and tear occurs, that is passing through the feces, and that is a loss of iron through the feces. Or sometimes those iron which is not absorbed, that also excreted through feces. And also by the desquamation of the skin. All the cells contain iron, isn't it? So our skin superficial cells are desquamated daily, small quantities. So during that desquamation, epithelial cells, iron may be lost very little amount. Then any bleeding. Bleeding means any time menorrhagia, females during menstrual period, or any gastric bleeding or intestinal bleeding, that will also uh, iron also will be lost from the body. Now we'll pass on to the functions of the iron. You know, that is hemoglobin in the blood cell transport oxygen to the tissues and returns carbon dioxide and protons to the lungs. So that is another important function. Then myoglobin in the muscle cells binds oxygen and stores oxygen as a reserve against the oxygen deprivation, and electron transport chain, oxidative phosphorylation, and cytochromes and certain non-heme proteins are there. So these are all important functions of iron. Then enzyme, iron as enzyme cofactor and a component of enzyme. We have already mentioned that it is acting as a component of enzyme. That is, as a cofactor, succinate dehydrogenase, aconitase, and ribonucleotide reductase. Component of an enzyme is, that is, xanthine oxidase, cytochrome reductase, acyl coenzyme dehydrogenase, and NADH reductase. Then it has got an immune function. Iron has got an immune function, and and it is used for the drug detoxification. That is, it is present in the cytochrome P450 enzyme, and it is used for the detoxification, and it exhibits antioxidant property as it is a component of catalase or peroxidase. So it has got an antioxidant immune function and also for use for the detoxification. Now we can pass on to the deficiency. Iron deficiency is one of the most commonly known forms of nutritional deficiency. Out of the nutritional deficiency, iron deficiency is the most common one, and direct consequence of iron deficiency is the iron deficiency anemia. So if there is iron deficiency anemia, the direct effect is the production of iron deficiency anemia. So this is the assessment of iron deficiency. Transfer in normal level. These are all the normal values. Transfer in normal value 250 milligram per deciliter. Serum iron 120 microgram per deciliter. Total iron binding capacity, that is another method of estimating the level. 400 microgram per deciliter. Iron store is 1000 milligram in our body. Absorption is 1 milligram. Even though we require 10 to 20 milligram, we can absorb only 10%, that is 1 milligram per day. Now, iron deficiency anemia, what are the causes? Chronic bleeding from mouth or nose or intestine or uterus, anywhere, chronic bleeding if it is there, peptic ulcer bleeding, ulcer in the intestine, everything will cause iron deficiency anemia. Inadequate intake, if you are not taking proper diet, that is iron containing food, then in a chronic case it will develop anemia. Then hookworm infestation. Hookworm will suck the blood in the intestine, so that will again cause anemia. Then repeated pregnancy. If the previous days repeated 4 or 5 pregnancy occurs successively, so that the mother will be having iron deficiency anemia. Then nephrosis, renal problem, where the erythropoietin is not formed and that will produces finally anemia. Then peptic ulcer, bleeding, uterine hemorrhage, and lead toxicity. Lead is inhibiting the iron absorption very much, so it is also produces iron deficiency anemia. Now I will classify the anemia. Impaired production of RBC, intracorpuscular defects, and the extracorpuscular causes. That is, first is production defect. That is defect in heme synthesis, defect in regulators, defect in stem cells. That causes iron deficiency. Then intracorpuscular, that is inside the cell. What are the causes for iron deficiency? Hemoglobinopathy, thalassemia, deficiency of enzyme G6PD, glucose 6 phosphate dehydrogenase deficiency. This about all these things you will study during the metabolism. Then extracorpuscular cause some infection, autoimmune infection, then isoimmune hemolysis due to drugs. All this again causes anemia. Now, what are the symptoms? Pallor, fatigue, apathy, headache, faintness, breathlessness, palpitation, irritability, lowered memory, poor scholastic performance. So, usually anemic patients will be pale. If you look at the face, it will be paper-like pale, and if you see the eye, it is also very pale. Tongue will be pale, and the undersurface of the tongue will be pale. Under sclera conjunctiva will be very pale, and the fatigue, always tiredness. The patient used to lie down always. Apathy, no interest to anything, and they may be suffering from headache, faintness, sometimes giddiness and faintness when they stand sometimes in the sunlight or long time for some time. Suddenly faintness occurs, and breathlessness, that is rapid breathing, occurs when they climb steps or walk for a long time. And then palpitation, heartbeats will be very fast, that is tachycardia. Then irritability, always irritable, they are not in the mood of not in the good mood, always getting irritated. And lowered memory, they have poor memory and poor scholastic performance, they perform very badly in the schools. These are the picture apathy, without any interest she is lying. This is the picture where koilonychia, flat nails, occurs in the spoon-shaped nails occurs in the iron deficiency anemia. One symptom, important symptom. Then there will be glossitis and all. Lips are inflamed and swollen. Angular stomatitis. Then diagnosis is by microcytic hypochromic anemia is the picture where the hemoglobin level is less than 12 grams per deciliter. Normal is 12 to 40 grams per deciliter. Then this decrease in serum iron, TIBC will be increased, and transferrin level also increase. Only when transferrin increased we can absorb more. So in iron deficiency anemia, transferrin level will be increased. This is the picture where you can see the anemia. This is the normal blood picture, color of the RBC and all. This is the pale RBC, microcytic, size also small, hypochromic and microcytic anemia. The treatment is iron supplement, oral iron supplement. First, you can advise some diet rich in iron. Then you can prescribe oral iron supplement. There is a nutritional program called National Nutritional Anemia Prophylaxis Program, where the iron and folic acid together is given to pregnant women and the children. So here 100 milligram of iron with 500 microgram of folic acid is given to pregnant women per daily for 3 months. For children under 5, 20 milligram iron and 100 microgram folic acid is also given for 3 months. So to prevent the development of anemia, that is not a treatment, it is prophylaxis to prevent the development of anemia. Usually the pregnant women will go for anemia. Similarly, children also, because they are not taking proper food, only milk and all, then the iron containing foods are not taken, so they will develop anemia. Then we'll pass on to the toxicity of iron. Few words about the toxicity. Large amounts of free iron in the circulation will cause damage to the cell in the liver, heart, and other metabolically active organs. So, free iron is always dangerous. Iron proteins is okay, but free iron, if it is present in the blood, it is very dangerous. So, in that condition, that will cause oxidative stress, and that is called the iron toxicity, and it is a serious disorder, especially for the children. How it occurs? If you take iron tablets overdose, sometimes the children will take one or 10 or 20 tablets together. It will appear like gems, Cadbury's gems, small round things. So they will think that it is Cadbury's gems and consume altogether. So that will produce toxicity, iron overload. Then it is associated with a genetic disease, mutation in the gene that encodes the epsilon. We have studied that the regulation is by the epsilon. So if there is any mutation of the gene which is producing epsilon, there is no regulation of absorption. So more of iron is absorbed, that will produces iron toxicity. Then there is condition repeated transfusion, blood transfusion, that is usually seen in hemophilia persons, thalassemia patients. They require the treatment, and the treatment is mainly repeated blood transfusion. So if they are doing repeated blood transfusion, sometimes they may go for iron toxicity. So iron overload can be divided into hemochromatosis and hemosiderosis. In hemochromatosis, there will be some injury to the cells where the iron is accumulating. But in hemosiderosis, without any injury to the cell. Hemochromatosis may be primary due to inherited disorder, or it may be due to secondary. Secondary may be due to any causes where the overload occurs when the iron is cooked in the iron vessels, and then that is seen in Bantu people. They used to cook the iron food in the iron vessels. So long time that will produce iron toxicity. Primary or hereditary chromatosis is inherited one. It's autosomal recessive. There is massive accumulation. Pathogenesis is hereditary defect in the regulation of iron absorption. Bronze diabetes is one where the accumulated iron will produce liver cirrhosis. Pancreas, it will cause diabetes. In heart also it will accumulate. And iron accumulate in the skin produces a slate blue color. And a triad of signs, that is diabetes, skin pigmentation, and cirrhosis, altogether causes the bronze diabetes. So if there is excess deposition in the pancreatic cell, that will produce diabetes. If this present in the skin, it is producing a color. Then in the liver, it produces cirrhosis. So cirrhosis, diabetes, and skin pigmentation together seen in the iron overload or hemochromatosis, that condition is called bronze diabetes. It has got an increased risk for hepatocellular carcinoma. If bronze diabetes is there, it may be going for the hepatocellular carcinoma in the later stage. The secondary hemochromatosis is due to ineffective erythropoiesis, repeated blood transfusion, and patients with hemodialysis. Investigation: how will you find out the iron toxicity? Transferrin saturation is more than 62%. Serum iron will be increased. Serum ferritin also will be increased. So transferrin saturation 1/3, usually 1/3, it will be more than 62. What is the treatment for iron overload or iron toxicity? We have to do repeated phlebotomy. What is phlebotomy? It is cutting off the vein and letting out of the blood repeatedly. You can cut down the vein at the lower leg and then let out the blood for some blood is let out, so that the overloaded iron is lost. That can be repeated several times till it is normal. Another method is chelating agents. Desferoxamine is a drug which can chelate the iron, which forms ferroxamine with iron, and it is excreted in the urine. So desferroxamine combines with the excess iron to form ferroxamine, and it is excreted in the urine. That is another method by which you can treat the iron overload. And you have to monitor when you are giving repeated blood transfusion to a patient's under treatment like hemophilia or thalassemia. Okay, so that is about the iron deficiency anemias and iron toxic things, that is hemochromatosis and hemosiderosis. So now you have studied how iron is absorbed, what are the factors affecting absorption, recommended daily allowance, sources of iron, then regarding the transport, how it is transported as transferrin, it is deposited, storage is in the form of ferritin or hemosiderin, and what are the main functions of iron, and then about the iron deficiency anemia, and what are the findings in the iron deficiency anemia, what are the causes of iron deficiency anemia, how will you treat the iron deficiency anemia. Then if there is excess iron, what is the cause, what are the different types, hemochromatosis and hemosiderosis, and how will you manage the case. So it is an important question. Usually source, RDA, absorption, transport, and storage of iron. Can ask as a 5-mark question. Source of iron, recommended daily allowance of iron, absorption of iron, and the transport of iron, and the storage. So storage is in the form of ferritin and hemosiderin, transport in the form of transferrin, absorption, ferrous form, various factors influencing and increasing and decreasing, and it is taking place in the duodenum and upper part of jejunum, and it is under the mucosal block theory, and hepcidin is the key regulator, and these are all the things regarding the iron metabolism. It is a very important topic. You can see almost all question paper contains one or other question of the iron metabolism. Okay, thank you.